Well, good morning, everyone. I'm Jim Berg. I'm the psychology coordinator for the board here at OCAMPR. And I'm excited to introduce to you Sandy Everett, who holds a bachelor's degree in psychology with double minors in behavioral neuroscience and Jewish studies, and has a master's degree in occupational therapy from Stockton University. Sandy works as a full-time occupational therapist at Anne Klein Forensic Center, the main psychiatric hospital in New Jersey that offers treatment to people in criminal justice system with severe mental illness. Sandy has additional training in behavioral approaches and techniques of cognitive behavioral therapy, including a certificate in a course titled Reasoning with Unreasonable People. And as an academic dean, I would love to take that course.
There's no hope.
She is a member of St. Ananias Coptic Orthodox Church in Monroe, New Jersey, and has a passion for Orthodox Christian theology and worldview, especially exploring how it informs her professional role. She's pursuing a second master's degree in theological studies from Agora University, an Orthodox Christian institution. Sandy.
Thank you. Good morning, everybody. Thank you for coming to this presentation and making your way all the way across the street. So I'm Sandy. I'm the occupational therapist working at Anne Klein Forensic Center. And yes, I work in forensics, and it is characterized by barbed wire, fences, and it is a pretty interesting place. From the outside, it looks kind of dark and gloomy, but the inside has become to me kind of a pleasant, quaint place. And forensics really means something within the legal system. We do not do DNA testing in our facility to determine the crime, evidence in a crime or anything like that, but it's related to the criminal justice system. People who have been psychiatrically involved, or people with psychiatric conditions who committed some serious crimes are often admitted to our hospital. And it seems like an oxymoron, forensic and hospital, because it's one of the very rare circumstances where you're admitted in a hospital that you can never, ever get yourself out of. No matter how much money you have or power, once you're there, there's very little things you could do to get out. You just have to follow the system. So it's not the most pleasant place for patients to be, but we are a rehabilitation hospital, and we do have 200 patients, give or take, in our hospital, a lot of which have committed some pretty severe crimes, including most common murder, aggravated assault, and illegal possession of weapons, and we have some Megan's Law criminal offenders with severe sex crimes. So it's a very interesting clinical setting. Every day is very different. And you might be wondering, well, why occupational therapy? This is not an actual appearance of what it looks like. I'm not allowed to take pictures of the inside, but this is very similar to what a day in the life of a patient is like. The system is set up almost like a prison system, but we call them patients. They're not inmates because of HIPAA rights, and we do honor, they have a lot of rights once they're at Anne Klein. So there's the patient-inmate dilemma. I refer to them as patients. And as you can see in this picture, some of them are unfortunately very violent, that the only way of really communication or transporting food items is through this little port. And even then you might get some punches. But our patients, for the most part, they follow rules with some exceptions. And you might be wondering, well, what is occupational therapy actually doing? It's not like they're looking for a job. Or they're gonna, work on their resumes. Mm-hmm. Well, that's kind of what I want to clarify, is that occupational therapy is not about finding a job. It's not what many people think about using fine motor coordination to help little kids in schools. It's more than that. It's engaging people through the use of activities and through occupation. And occupations really are meaningful activities that occupy a person's time. They could be routine activities that a person no longer engages in because of a disability, or they could be more unique things like hiking or golfing, so leisure tasks. And we use, as therapists, occupation in our treatment plan, so that's very characteristic of what we do. We are healing through doing is what our motto is. And just a brief history, occupational therapy did grow out of the moral treatment for people with mental illness, giving them things to do and quality of life instead of nothing to do and a lack of purpose. And group therapy is actually a hallmark of what we do, because one of the beliefs is that group life happens in groups, and that's one of the main occupations in life, is being able to deal with someone in a group environment. And hopefully in that group setting, we teach people how to reduce their risks for reoffending, to reduce recidivism risk. And we do it through activities, and we talk about them, getting them through the process. So my role is to challenge a lot of them, but not too much, and I'll talk about that later, and elicit some emotions and thoughts and memories and see how they will respond, and we work through that. But it's really through activities and through group therapy. And now you see a lot of occupational therapists working with children, with outpatient hand therapy, and geriatrics, and I have experience in all these settings until I found my niche in Anne Klein. I did leave these little cute babies, and I went to my forensic patients. So now that you know a little bit about me, I want to know a little bit about you. So hopefully you took the time to get yourself on the polling. If not, just spend like 30 seconds. You're going to text Sandy Everett 910 to the number 22333. It's anonymous. So it looks like, so the question is, which of the following best describes you? And 38% of the people here are clergy. 33%, okay, don't mess with me. 33% are clergy. 11% are caregivers. 11% are mental health professionals. 11% are medical professionals. And 33% are curious learners / lay people. Okay, great. Welcome. That's good to know. And then we might have a questionable. The next one, which of the following best describes your current attitude about the topic of client or patient resistance to treatment intervention? Okay. A, the way to overcome resistance is to wait for the client or patient to be ready. B, a skilled professional or caregiver should attempt to talk through resistance. Or C, developing relationship and trust should be the focus with resistant people. An overwhelming majority went for C, developing relationship and trust should be the focus with resistant people. And then 13% voted B, a skilled professional caregiver should attempt to talk through resistance. Okay, the next question is, are non-compliance and resistance to treatment or intervention the same thing? Yes, no, or I don't know. 22% of people said yes, that non-compliance and resistance to treatment are the same thing. 44% said no, and 33% say, I don't know. All right, so we'll get to some of these questions, and here are our objectives for the day. First, we're going to learn how the Orthodox notion of synergy really helps us to understand compliance and how that differs from adherence. And that's a term we haven't really talked about yet, but I hope to maybe redefine some terms. Understand scriptural and patristic insights on the importance of the human will in the change process. Gain insight from occupational therapy principles and a little bit of what I see on a day-to-day basis on how to deal with resistance, and apply these principles to real-life scenarios. So you will be putting on either your clinical or clerical hats to answer some relevant questions and scenarios. All right, so I would like to first just focus on why it's such an important topic, and why non-compliance and resistance are a big deal. And some fascinating statistics, I don't know if you can see it with the lighting, but 30 to 50% of patients don't properly follow medication instructions. Only 50% of patients take meds as prescribed. So you wonder what the other 50% is doing. 33 to 69% of hospital admissions are due to poor adherence. And the statistics are actually even worse for people with severe mental illness, especially people with on antipsychotic medications, which you really need antipsychotic medications for psychosis related conditions. And 40 to 60% are non-compliant with antipsychotics, 30 to 97% for antidepressants, and 18 to 56% for mood stabilizers. So those are pretty profound statistics. Okay, so now we want to examine the first objective, which is the Orthodox notion of synergy and how it helps us understand compliance and how it differs from adherence. In Orthodox Christian soteriology, the understanding of our salvation and how salvation works in our lives, we believe that synergy, or the Greek word synergia, is essential to salvation. That we must submit our will, whatever capacity of will we have, with God's grace. And it's a relational model. It's very much like a zipper, both working hand in hand together. And as it is relational, the will is key. It's not just a mental assent or agreement to a series of doctrines or a series of belief statements. But in Orthodoxy, we believe it's an actual relationship. And this is relevant to the issue of compliance. Because with compliance, although it suggests an obedience or a conforming to some parameters that are laid out, compliance actually connotes the opposite. It does connote, and I'm not saying these are bad, a behavioral change without internal acceptance. It connotes a passivity and a blind kind of obedience, whether you agree with it or not. And I'm not saying that's a bad thing, but maybe there's a little bit of a more superior term, which is now in most recent medical models, which is adherence. We want to look at actual adherence of clients, of patients. And adherence really deals with the person's response, willful response to treatment, in agreement and in accordance with the advice of their caregiver or their advice giver, clinician. And as you could see from the difference between these two, the intrinsic drive, the partnership, is a hallmark of adherence, and it's very active. And the will is key. That's the main difference between the two. In one aspect, there's some kind of acceptance and compliance, but maybe it's temporary. Whereas in adherence, there's almost a synergy going on. There's a partnership between the caregiver, the clinician, and the actual patient. Okay? And in psychological models, schools of thought, bless you, there is a theory that there are 5, maybe 6 stages of change. And it's really important to assess. So what I do and what other clinicians in our hospital does, we talk about where is the person at. We assess them. At what level of the hierarchy are they at? Are they first pre-contemplation, which is unaware of the problem, contemplation, aware of the problem, of the desired behavior change, preparation, they're intending, maybe talking about making change, or action, practicing their desired behavior. And maintenance is sustaining the behavior. So you can see in this chart that if you really want to get to compliance, you might be at the very lower level of contemplation, preparation, doing certain superficial acts. And this might also be true in our own spiritual lives as well. This is linked to how we can be compliant. Just doing things, going with the motions, and then it fizzles out after a while. But a person who's more adherent is going to be more engaged, action-oriented, and hopefully maintaining in that level. So, taking basic exercises as an example, if you have a, this might be a real-life example, a spouse who is constantly nagging the other spouse to exercise all the time and eat healthy, maybe that's an extrinsic motivation to get them to the gym and maybe on a special diet for like a week, and then it fizzles out. But then if that person just finds some intrinsic motivation and comes to it on their own will, maybe with some help, but it's from their own will, then the change is most likely to be permanent and it permeates their whole life. And this is what we want to see in all aspects of life, is that synergy of the will with what is actually good and true. So objective number 2 is how we can look at the scriptures and patristic principles on the distorted will. And what better way to start than the example of Jesus and how he, even as the omnipotent, can do all things, he couldn't even heal through a completely damaged will. And we see this in Mark 6:5, that Jesus, he could not perform any miracles there except to lay his hands on a few of the sick and heal them, and amazed at their unbelief or unwillingness, he went around teaching from village to village. So is this an example of resistance or unawareness? Sometimes the line is a little murky. It's a little confused, but we can see that the will is essential for God to even heal, for synergy. And there's plenty of other examples, but we can also look at monasticism and how they are focused on the discipline of the will. So I guess a question you can answer yourself is, what does it mean to be a willing person? When you think of someone who is willing, what are some of the characteristics associated with that kind of person? And most people, maybe in Christian circles, will associate a monk with a willing person, or a servant in the church with a willing person. And usually it means someone who is willing to do, someone who does. It's not necessarily someone who thinks. Thinking doesn't really get us too far in terms of our rehabilitation or helping people who are resistant. A lot of times we can't think our way out of things. We have to sometimes do our way out of things. And monasticism is a great example of how they recognize the value of work. This is a real picture of our visit to a monastery in Texas, of a monk feeding the little goat. And a lot of these monks, they come from backgrounds, maybe medical, engineering. They had good careers. They're not doing this to gain a profit, but they understand the discipline of the will of doing is essential for their salvation, of their spiritual growth. And it's prescribed to them. In fact, it was one of St. Anthony the Great's greatest struggle. One of his struggles initially was restlessness, or maybe like a lack of purpose, which is known as anxiety. So I will read this passage from the sayings of the Desert Fathers to really highlight how God prescribes work and doing to heal the restless and unwilling soul. except he was more willing. So when the holy Abba Anthony lived in the desert, he was beset by anxiety and attacked by many sinful thoughts. He said to God, "Lord, I want to be saved, but these thoughts do not leave me alone. What shall I do in my affliction? How can I be saved?" A short while afterwards, when he got up to go out, Anthony saw a man like himself sitting at his work, getting up from his work to pray, then sitting down and plaiting a rope, then getting up again to pray. It was an angel of the Lord sent to correct and reassure him. He heard the angel saying to him, "Do this and you will be saved." And at these words, Anthony was filled with joy and courage. He did this and he was saved. And hence we get the spiritual rule in monasticism of work. And it's really essential for work. And there's consequences to monks who are unwilling. I mean, there are spiritual consequences in addition to maybe some external consequences as well. Which gets me to one of my favorite sayings or truisms. It's actually an Alcoholics Anonymous saying, which is, "It's easier to act your way into a new way of thinking than to think yourself into a new way of acting." So sometimes with resistance, there is stagnation, there's unwillingness, but it's not enough to just think our way through it. We actually have to do something. And one of my other favorite stories from the lives of the Desert Fathers is one of the monk who was weaving baskets. That's a very common monastic thing. And after he runs out of materials, he doesn't want to fall into boredom and just lack of purpose. So when he runs out of materials, he unweaves the ones. After going through all the steps, it's very complicated. He unweaves it and then puts it back together. So creating more work for himself. So you can call it busy work, or you can call it actual healing of the will and discipline. And I give you examples of people who are actually self-aware and have insight into their human condition. But I think what we're more interested in is what about the people who are actually really struggling, who have they're on the spectrum of a really broken or a divided will. And we know from James 1:8 that a double-minded man or woman is unstable in all his or her ways. So on one side, we know what is good. We know what it's cognitively. We can rationalize what is good for us. But on the other side, there's a draw to be pulled into some behaviors that might be maladaptive or not good for our functioning in the world. And St. Paul also wrestles with this. He's kind of vague as to what he's really struggling with, but he says, "I do not understand what I do, for what I want to do, I do not do, but what I hate, I do." That's Romans 7:15. So people might understand that their addictive or impulsive behavior, their anger issues in mental health are bad. They know it. But there's a part of them that they have to operate in that way because it just gives them something. So there's that resistance to change because maybe that's the way they've been trained their life. It meets some needs, underlying needs. So there's an example of actually a patient who approached me a couple weeks ago. She was about to get discharged, and she's like, I'm kind of scared to get discharged because I feel like I'm gonna be high again, because all I think about is being high, and I don't want to live sober. So then I asked her questions about the past 7 months where she's been at our facility. That's a long time, where she was following the rules, and she was able to say, yes, I was following the guidelines, I was able to participate, I enjoyed all the activities we did, the baking, the cooking, I learned a lot. But she said, despite that, I'm so used to, and it's so scary for me to give up being high over being sober. So she was really, I kind of commended her for her insight, that you're really developing that insight into the struggle. It is a struggle, and you validate that. So, and St. John Chrysostom does comment about this, and he does say there is a part of our soul that governs consciously with reason, and another part of the soul that is pulled it's kind of like an animalistic side that is pulled by other desires of the world. And that's in Homily 13 on Romans. So now I'm going to talk about what we actually do. So gaining insight from occupational therapy on principles and how to deal with resistance. So I want to argue that occupational therapy has some really interesting things to offer to this topic, and they might be just really out there because a lot of us are really out there when we think about how to deal with issues. I'm going to use some of the theoretical frameworks to describe from a fresh perspective how to deal with resistance. And even though I use these in mental health settings, I firmly believe, and they're definitely tested, and for the most part, they work in other settings. Because I have worked in other settings, and people are similar in after all. So they could apply whether you're a caregiver, a clergy person, or a mental health professional. The first principle, and these are not hierarchical, they're just for the sake of ordering. The first principle is really connecting with the will through the use of activity. So talk-based therapy is great, and we use it. We're trained to use it as one of our techniques, especially cognitive behavioral therapy, DBT, and motivational interviewing. Those are hallmarks of dealing with resistant people, and you might want to look further into that if you want to develop some more skills. But it's not enough to just stop there. And to illustrate this, I would like to show a quick video.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail out.
See, you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way.
All right. So what's going on in this video? There's so many different things going on. It depends on which perspective. I mean, I think this could also be used in like couples and family therapy, just validation and just really listening. But talking a lot of times doesn't actually solve the problem right then and there. It doesn't always increase awareness, and it doesn't always... And sometimes that's not what the person needs at that moment. And one of my favorite quotes by Plato, who's actually a talker, he's your epitome of a conversationalist. I mean, he would sit in the marketplaces and just talk and dialogue with people. He said that you can discover more about a person in an hour of play than a year of conversation. And this really highlights the impact of activity. You can define play, whether you're an adult or a young child, as something pleasurable. Leisurely, or something that gives you meaning that you do with another person. And this is one of the things that I believe has made me really into my job. I really value what I do because I am very engaged with the patients despite their very dangerous history and the capacity for a lot of damage. But one example of how I use this is through basketball. So this is... Diana Taurasi, she's my crush. She's my female crush. I admire her. And I do play basketball a lot with some of the big guys in the gym at work. It's something that no one really does. A lot of professional staff, they'll be in their offices or in like a small group setting. But I do have some free time on a daily basis where I can go and engage with certain patients that are very difficult on the basketball court. And what I've learned is one particular patient, he has been on so many behavioral plans. I don't know if you know those kind of behavioral plans, just very specific. If you do this, then that. And those are fine. A lot of people were just complaining. He's always inappropriately touching people. He's limit testing. He's just difficult. He's very belligerent, disrespectful. So they're seeing all these behaviors. And then I'm on the basketball court, and he's suddenly just developing these skills of respect, boundaries, even just being he's this big guy, just extra cautious of like where I am at. Like, I want to just give you space. I want to make sure that, are you okay? And that's really the kind of through the activity, not just talking, I was really able to see he has the capacity, and I do report it to the team. Like, he has the capacity to be very respectful. It just depends on how you really approach it and how you see actualized. So that's an example of dealing with very challenging circumstances in an unexpected way through activity. And really what the key is not just the activity, it's the process, and it's the therapeutic use of self, which is even more important. It's probably the most important hallmarks of occupational therapy is how we use ourselves in a therapeutic way. So to define it, it's the planned use of therapist personality, their insights, perceptions, and judgments as part of the therapeutic process. A lot of disciplines do have this as well. It's more something that I just believe it's the most important thing in dealing with very resistant people, because you really, it's an exchange. It's all about partnership. And when we talk about synergy, when you put yourself out there, your personality, your talents, your insights, you get an exchange back. It's not like hitting a brick wall. And it also takes a lot of reflection. So being able to reflect and to discern if my approach is going to be good for one person, it could be totally ineffective and harmful for another person. So that's where we use our, not clinical judgment, but just being very therapeutic and being trauma-centered. So an activity in the kitchen for some person can really elicit a lot of trauma because maybe they murdered their family member in the kitchen, which is very common, unfortunately, because there's a lot of weapons in the kitchen that could be misused. So I have to be mindful of that and maybe to do it elsewhere. So that's how we can view the person as unique and use ourselves as a therapy tool. And at the end of the day, sharing in activities together with people, no matter how difficult they might be or challenging, makes them feel special and valued. And an example of this was a patient who is constantly just what we call food seeking. She just wants food all the time. If you think of the hierarchy, Maslow's hierarchy of needs, she's kind of like at the very bottom of just food, shelter, basic. And she's always thinking that I stole her food. That was a delusion of hers. But sometimes that delusion is kind of, if you scratch the surface, it's okay, it's at bay. So I would curb that kind of behavior. She's always seeking food. Well, why don't we just do something productive and actually make food? So we bake pumpkin pies together. And, her planning and her perception and her reality orientation, just very focused. Unfortunately, that same patient that I have been working with for a year and a half, she assaulted me actually last week. She violently attacked me at the hospital, and I'm no longer allowed at this time to work with her because of her delusions just got out of control, and she couldn't control her impulses. But it's part of, the risk of being in that environment. But sometimes these techniques do work temporarily to get something productive out of the person. The second part that is really important is using a personalized and unique approach for each person. Everyone is very unique, and that's being created in the image and likeness of God. We're going to express our personalities, our interests. Everything is going to be different about us, and that's okay. And one of the models of occupational therapy is to understand that we are an open system So a person who might experience resistance is not a closed system. It's still an open system with different outputs, whatever they exude out, and different inputs, things coming in from their experiences. But they might process it differently in their system based on their sense of volition, their values, their interests. And we need to know that. What does the person actually value? What are they interested in? Their habituation, so their routines and habits. If medication has never been part of their routine in their life and they're now the age of 70 and asked to take medication, there might be a problem because of how they are organized internally and their performance skills. So like their cognition, their neuro abilities. So every person has to be treated uniquely. And an example of that is I try to instill an activity, a daily routine in my patients of gratitude, especially around this time of year. And they were kind of resistant to the idea of journaling every day. So I didn't impose that on them, but instead I asked them what their routine is, what is it about their daily life in the morning that makes it hectic to do something like that. So then I realized that hygiene is important to a lot of them. They like to put on their lotions. That's the only like sensory thing that gives them pleasure in the morning. So then I was like, okay, great. What we're going to do is make lotion from scratch. So we got all the supplies to make healthy, organic kind of lotions. And they got the chance to pick essential oils to put them in their bottles. But I was like, here's the caveat. What you're going to do is put a label on your container, a very unique label, of a synonym for gratitude, something that you're going to literally or metaphorically put on every morning, like blessing or peace or forgiveness every morning. And they were very willing to do that because it was part of their already established routine. It was unique to them. It was personalized. And I wasn't enforcing it on them or imposing it. So there's a difference here between control and collaboration. And then finally, how to implement this is really important because we can, talk about different ideas, but everyone, again, is different, has different capacities for doing. And I would like to introduce the Just Right Challenge. I don't know if everybody is familiar with it, but it's one of also a key occupational therapy terms where we optimize the performance of a person by matching the skills of the person to the demands of the activity. So we're kind of setting them up for success, but we also are getting to know their skills, so we merge the two. Because a lot of times when people become resistant to whether it's work or discipline, it's because things can seem overwhelming. They might be overwhelmed and overstimulated, overburdened by other things in life. They don't know where to begin. Or they could just be very disinterested. It's not something important to them. Or trauma, especially in mental health. People can be resistant because of trauma. And they might need to heal through that or find a different way to do something because of their previous trauma. So resistance really is a double bind. We have to find what's causing it and work through it. So if we don't find the just right challenge for the person, they become resistant and stuck, whether we're helping them as a caregiver or a clinician. So they could either, what they view as a double bind is that they could either continue to live in their past and their of pain and trauma, and if we give them an unattainable task, such as do this every day, without really understanding their capacity, then we're setting them up for failure over and over again, and they're going to experience more pain and hurt and trauma from that. And a lot of times it's just very, it adds up over time, and people just become resistant and maybe not even trust the advice of caregivers or clinicians. And that's what we see a lot. So just the Just Right Challenge is finding something that they could potentially do successfully and then building up from that. So an example of that, this lady, it's not a real person, that I know, but there was a person I actually treated that looked and sounded, exactly like that. Just anytime you walk into her room, and it was in a nursing home facility. It wasn't even mental health. No one wanted to work with her over time. She would scream at you, curse at you, and she couldn't really move, and that was the problem. But her weapon was just screaming and terrorizing you, and her eyes would open up. You can put in all your theories of what's going on. Changing her voice, it was quite scary. So psychologists did assessments. They said she's fine. She has no history of any mental health condition. Her daughter said she's been completely fine all her life. She's 76 or 77 at this point. So I asked what happened in the past 3 months or recent history that made her like this. Said, well, she was in another nursing home, and the caregivers, the nursing assistants, used to pull and tug and scratch and roll her, and she was very traumatized from the experience of being cared by another person, that she doesn't even want anyone to touch her, no one to even come in the room. So I didn't want to just go in and do something like everybody else, which is touch her and roll her. And, sometimes as therapists, we have to be very physical. But, why am I going to repeat the same thing over and over again? So finding out her trauma. And then I asked, well, what does she absolutely love? What is one thing she wants to do that would just get her out of bed or something? All she wants is Chick-fil-A. All she wants is to go to Chick-fil-A. That's what we used to do on a daily basis. Ever since she retired, we would go to Chick-fil-A, and she loves the atmosphere there. I said, okay, that's great. Are we willing to not have her walk, but just get her out of bed? She hasn't been out of bed in 3 months. She's been in bed for 3 months. Can we just slide her using a sliding board, for example, just to slide her into a wheelchair and just be happy with that and settle for that? And for the first time in 3 months, the patient was actually able to get out of bed and sit upright in a chair. And eventually they were happy with not having her stand up, even though there's a lot of initiatives by the hospital to get her. She's got to stand, she's got to walk, get to previous level of function. But we got her out of the bed. That's a celebration. So the daughter was actually able to arrange a day trip using one of the Access Link or hospital vehicles to get her into a Chick-fil-A. And so she accomplished that task. And it was kind of like a win-win situation. You accomplish a goal and you help heal some trauma and hopefully build a little bit of trust with the person. So now you heard just an overview of the different principles. Firstly, using meaningful activities and that are relevant. Talk therapy is great, but maybe we can do more with the person instead of just talking them out of their resistance. We could do more through activity. Approaching each person as a unique person and finding something individualized and looking at them as a whole, their daily routines, their habits, their beliefs. And then how to implement the therapeutic use of activities using the Just Right challenge, doing something that's just not too difficult, not too easy, but just right. So those are the 3 main principles. And we do have some time to do our 4th activity, or the workshop activity of the day, which is splitting up into 3 different groups. You can split up based on your background. So if clergy people want to get together and discuss the case study that's more clerical in nature. I have a scenario for caregivers, and I have a scenario for clinicians. So if we want to take just 5 minutes to do that, and then we can discuss, and then I can answer some questions, but we'll do that now. So we'll pass the microphone around if that's okay, because we're recording this for people who are not here. But if one person just wants to read the scenario briefly, and then another person can share what the consensus was. If there's a division in the group, then we can hear from different perspectives. But we do have 3 to 4 minutes to go through all the scenarios. So let's start with scenario number 1. Allie.
Okay, so scenario 1 is Allie. Allie is a 23-year-old female who recently graduated from college after being away for 5 years. She was baptized and somewhat formed in the Orthodox Church when she was about 18. She did not form long-lasting relationships in the church due to being an immigrant in a mostly American-based church and because of a number of cliques that have already been developed in the church she grew up in. The priest of the local church has called or texted Ali several times to invite her to church, but to no avail. You are the ministry leader in this case and planning the next steps. So in developing the scenario, me and Father Michael were talking and, looking at this as we think Allie's probably a young woman who studied molecular biology at university and had intended to go on to medical school but was unable to attend. So in addition to some of the conflicts within the church, she also has some issues with her immigrant family that was really, really looking forward to her going on in America to becoming a physician. So we go on to, how might meaningful activities might be used to overcome resistance in this situation, and what information would you need to know about the person? And we kind of talked about as the way we'd approach it would probably be try and take her out to lunch and sit down and talk to her and find out, what she enjoyed about what she studied, what she enjoys in her playtime, her free time, and what really gives her meaning in her life. And the idea behind this is that this will allow us to know her preferences and uniqueness, and the way this helps us intervene effectively is that we are all individuals created in the likeness and image of God, but we are unique creations. And, you're trying to help her as who she is, not just a 23-year-old female from an immigrant family, who was unable to attend medical school, but her and where she's at in her life. And then lastly, it is, what could you do to make this intervention just right for the person's individual needs? A lot of it is, keeping communication with her, open as you're trying to find out how you can introduce her into the parish life, not just to people, but to its activities, and giving her opportunities if she wants to participate at the level that she wants to. I mean, some people want to be deeply integrated, and some people just are happy being at the periphery as long as they know they're welcome there at the periphery.
Thank you. Great. And I really like how you focused on her stage of life. Developmentally, she's just got out of school. It's really important to know that about the person, because maybe her focus is developing her career at that point, not necessarily the spirituality, but you can then do your clerical work through that avenue, her strength, her focus, which is really good. Taking her out to lunch. No, that's awesome. All right, group number 2 is Bill.
Okay, so scenario 2 is Bill, an 82-year-old man who was recently sent home after a long pneumonia hospitalization, and he has some weakness, and he has difficulty resuming daily activity, and he's been resistant to the therapists that have come or the people who have come to help take care of him, including the home caregiver. So he's not doing a lot of the daily tasks and doesn't seem motivated. And we are supposed to be the caregiver in this case and planning the next steps.
So what we suggested would be a meaningful activity for him to overcome his resistance in the situation, would to be to find out what he enjoys doing. One of the main goals was to get him back to his regular daily activities, and the activities that they listed for him seemed kind of the activities that he would do in order to heal. So maybe involve activities that he did prior to his hospitalization. So we suggested, let's say he likes baseball, he loves watching baseball. So we suggested that maybe we incorporate that into his care plan. And we had a couple suggestions. That one, it could be that we let him watch baseball, that's part of the routine that we do with him. 2 was that we had going to a baseball game to be a motivator, he needs to get this certain amount of strength in order to go to the baseball game, and make that happen for him. Question 2 is, how would knowing this person's preference and uniqueness help intervene effectively? It would just give him motivation and kind of bring him back and make him feel like a real person again. I feel like oftentimes people, when they're hospitalized and they get back, they still kind of feel like a patient in their own home, which can be very difficult for them. So to bring him back into feeling like he is himself, how he was previous to his hospitalization is really important. And then how can we make the intervention just right for that individual? It's to make sure that he's able to do it physically. He lost a lot of muscle. So if we're going to bring him to a baseball game, make sure that there's accommodations. If he needs to be in a wheelchair, it's wheelchair accessible. If not, then he needs to get a certain amount of strength so he doesn't fall or have an accident, which would then make the trauma even worse.
Scenario 3 is Cindy, for the clinician to consider. Cindy is a 34-year-old married woman who is severely depressed with a recent diagnosis of postpartum depression. She's selectively mute, wants to sleep all the time, doesn't demonstrate goal-directed behaviors, except for going to the bathroom. She displays a disheveled appearance and refuses to eat 75% of the time. She has been too ashamed to accept home therapy services. You are the clinician assessing the case and planning next steps. In this situation, we want to appeal to the senses of this woman and meet her where she is at. Some considerations include giving her an option of which slippers or shoes to put on as she leaves the bed to walk over to the bathroom, choice in the opportunity to maybe take an extended walk outside of the home for fresh air, maybe through the yard and back, considerations for the bathroom to be decorated with scents of essential oils, lotions, flowers, things that would appeal to her. And we would want to inquire through her husband, types of foods that she would be most interested in, having those cooked or baked in the house to appeal to her willingness to eat. So these are just a few of the things, but we want to introduce choice, and we want to do it in a meaningful way that responds to her own unique and personal preferences and interests.
My final comments would be all these scenarios have definitely occurred. So, for example, with Bill, what he really wanted to do was go to a Dunkin' Donuts. Again, food and older people actually go hand in hand. It's like a pastime, going to a coffee shop and having donuts. So he wasn't getting out of bed, but when we said we have a setup in your own living room of Dunkin' Donuts and coffee, he was able to go. It was just right for him. He transferred into a wheelchair, and eventually he got walking again. So you guys hit the nail on the head, and you guys did awesome with your group, but it's showing just the power of doing and collaboration and figuring out really what is at the bottom of people's resistance and finding synergy as the healing tool for highly resistant people. And sometimes if it doesn't work, then we understand that there's different factors, and we have to refer people to others as well when we can't do something on our own. All right. Thank you.